I shall now demonstrate again exactly what I did. First, as with any examination, you introduce yourself to the patient. Greet them by name, check that you have the right person as on the records. So, hello, Mr. Vincent. I'm Janet Porter. I'm one of the clinicians here, and I understand that you have pain in your right shoulder. I then explain briefly what I wish to do. The patient does not need a detailed explanation of the procedure, just that it is going to involve you're looking at his shoulder, feeling it and moving it, and then you ask his permission. So I would like to look at your shoulder. That will just involve my looking at it, moving it and feeling it. Is that all right with you?
Yes, miss.
Okay. I need him to be adequately exposed, which in this case is just taking his shirt off. I need him to be visible from the waist up. In a female patient, you can leave the bra on, but all the other clothes must be removed. And you must do hand hygiene before and after your examination. So if you would take your shirt off, please, I will just wash my hands. The first thing you do is look. And you look from the front. There is no deformity of the clavicle. There is no deformity or undue prominence of the acromioclavicular joint. The muscles here are normal, the muscles here are normal. I then turn him round, I check the side. He has a vaccination scar but no surgical scars. And then I turn him round and I look at the back as well. From the back, I see that he has this shoulder slightly higher than that one. That's within normal limits. Most people's dominant hand is slightly higher at the shoulder than their non-dominant one. He has no problems with his thoracic spine, which is straight. He has no muscle wasting of supraspinatus here or infraspinatus here, and no apparent winging of the scapula. And from sideways again, the shoulder is slightly forward of the midline, which is again a common variant. His head is held slightly forward, but that is again not of any significance. I have specifically not looked for redness or swelling of the shoulder joint itself, because the joint is so deeply buried that that is unlikely to be visible. Right. I then need to feel. I warn him that I'm going to do this. I'm just going to need to feel this now. Use 2 fingers, usually of your dominant hand, and start here at the sternoclavicular joint. Move your fingers slowly and steadily along the line of the clavicle. You should be able to feel a forward curve and then the backward curve, until here you reach the joint line of the acromioclavicular joint, which is normally clearly palpable. There is then a further centimetre of acromion beyond that, and then you have the front corner of the acromion. You march along the edge of the acromion to the posterior corner here. Sometimes it's easier to feel if you turn your fingers round and approach it from that side. So there is the edge of the acromion. Immediately below that is a slightly softer indentation, which is the subacromial bursa, and below that is the head of the humerus here. The head of the humerus, provided the arm is facing forwards, you have the greater tuberosity here, the lesser tuberosity here, and between them is the biceps tendon running up the bicipital groove. So feel the greater tuberosity, the lesser tuberosity, and then turn your fingers round, and if you do that, you can feel the biceps tendon flicking to and fro underneath your fingers. The coracoid process is also palpable, but not usually felt because it's always uncomfortable and rarely the site of pathology. So I have felt all the normally relevant structures. The next thing is move. Do all of these, if possible, from the back, because you are interested in the scapular movement as well. So I want the patient first to do all 6 active movements. Remember, this is a ball and socket joint. You have 3 pairs of movements: abduction, adduction, flexion, extension, and external and internal, or lateral and medial if preferred, rotation. So could you please lift your arms up to beside your ears, guide the patient, but don't do it for them. Remind him that you cannot see his face and ask him to tell you if it's uncomfortable at all. So please tell me if that's uncomfortable. And can you now bring your arms down slowly? And what I am doing is watching the movement of the shoulder blades. It is smooth and symmetrical and even and painless as his shoulder blades come back to the normal position. So that is abduction, and he has 180 degrees of normal, pain-free abduction and a normal scapular rhythm. Would you now put this arm across your opposite shoulder and down, and this one across your opposite shoulder and down? That's difficult to measure in degrees, but it's symmetrical and painless. I then wish to check flexion and extension. So can you take your arms up to beside your ears, going forwards now? And again, normal scapular movement, and back and towards, straight towards me, so he can go straight through flexion into, I would estimate that as 45 to 50 degrees of extension, which is again the same on the 2 sides. The range of movement varies enormously between individuals, but it very rarely varies between the 2 sides unless there's something wrong. I will now do active rotation. So tuck your elbows into your side and swing the arms out that way. So his range of active external rotation is 55, 60 degrees. And symmetrical. Then internal rotation is most easily measured by how far the patient can get his thumb up his back in terms of the level of the thoracic spine. Remember that viewed from sideways, the sternal notch is at T2, the manubriosternal junction is at T4, and the xiphisternum is at T8. So he can reach to approximately T6 with this thumb, and with the other one, less far, T7, 8, but that's probably not significant. I would register it and look for it when I do passive movement. So he's done all 6 active movements. I will now test passive movement. So I take the weight of his arm and I take it right up, and I can take it up to 180 degrees, and overpressure at the end of that movement has a normal feel. It does not feel stiff or stuck, and it is not painful. So that is a normal range of movement. I would then test adduction. And for this, it is easiest to rest the patient's forearm on your hand, and you carry it across into adduction that way. This stresses the acromioclavicular joint here because you are carrying the scapula and the arm round the end of the clavicle here. Now, you can compare the other side. If there's any suspicion that this is abnormal, I would look at the other side. Because, as I said, movements vary between people, but they don't vary between the 2 sides of the same patient. In terms of examining for pain, as in palpation or as in resisted movements, there is really no purpose to be served by examining the normal side. Now, I do not normally, personally, test passive flexion and extension because it gives very little information, but you can include that if you wish. The next passive movement that I do is abduction again, but this time stopping scapular movement. When you do this, about 2/3 of that movement occurs because the scapula moves on the chest wall. If I wish to know what the shoulder joint itself is doing, I have to stop the scapula moving. The easiest way to do that is simply to press on the acromion here with your free hand. You then, again, passive movement and only the segment of the humerus here. I attempt to pull his arm into abduction until about there you can see and feel that this hand is starting to be moved. Beyond there, he cannot move his shoulder without moving his scapula. So he has a range of 60 degrees of glenohumeral abduction, which is normal. And if I was not sure it was normal for him, I would check the other side. The other two movements to check passively are rotation, and those occur only at the glenohumeral joint because it's the only ball and socket one. The easiest way of testing external rotation is to stand behind the patient, take hold of their wrists, use your forearm to keep the elbows into the side, and then swing both arms outwards this way. You can detect then quite subtle changes in external rotation. That is important because external rotation is the first movement to be lost in capsular or arthritic problems in the shoulder joint. Internal rotation, you don't exactly repeat what the patient did actively. Think of internal rotation as going from there straight through the middle of the patient's body and out the other side. Clearly you can't do that. So if it goes as far as that, drop the patient's arm down, put it back up the back, and with the humerus held vertically like that, just check that you can lift the patient's forearm off the back. You normally can just do that and it's not painful. So he has, and I would check it the same the other side. There's probably a few degrees difference, but it's probably not significant. So I have now done all the active and passive movements. I now do resisted movements because many of the problems in the shoulder joint relate to the muscles and tendons around the joint, particularly the rotator cuff. So test all 6 resisted movements. And the easiest way of testing any resisted movement is to put the patient's arm a little into the movement that you wish to check and say to them, hold it there, stop me moving it. You then pull in the opposite direction. So if I pull into adduction like that, I am testing his power of resisted abduction. He is using his abductors. Hold it there, stop me moving it. Resisted adduction. Just a little forward there, not too much. Hold it there, stop me moving it. There's resisted flexion, which tests biceps. Resisted extension, checking the latissimus dorsi here. Resisted abduction, of course, is supraspinatus. Resisted adduction tests subscapularis. Then patient's arm to his side like that. Hold it there, stop me moving it. That is external rotation, for which he's using infraspinatus here. And resisted internal rotation tests subscapularis. There were then 3 additional movements I tested. That is biceps, and resisted extension is triceps. Although they are primarily elbow muscles, the long head of each, of course, is involved in the shoulder joint and may therefore be the source of pain. And finally, I check the function of serratus anterior. If you have a convenient wall, you can lean the patient against it. Otherwise, have them push against your hand, and you can see whether there is any winging of the scapula on that side. That completes my examination of the shoulder. I do a quick mental review of whether it is necessary in this particular patient to examine his neck, to examine his chest, or even possibly to examine his abdomen as a source of referred pain. That's not necessary here. I might also, if he had, for example, had an injury, I might need to check joints further down his arm. I might need to check the nerve and blood supply to his arm. But that completes my examination of the shoulder. And the normal conclusion, again, of any examination, thank the patient, allow him to get dressed, help him if necessary, explain that you found no abnormality in this particular case, clean your hands again, and write your records.